The management of subclavian artery thrombosis. Welcome to the Everything Surgery podcast, where we dissect the extraordinary in surgical care. Today, we are focusing on the management of subclavian artery thrombosis, a serious vascular emergency that demands swift diagnosis and coordinated multidisciplinary intervention. This condition poses significant risks, including limb-threatening ischemia and embolic events, particularly involving the brain through the vertebral artery. As such, its management often requires collaboration among vascular surgery, interventional radiology, hematology, and neurology specialists. Let us begin by understanding the causes behind subclavian artery thrombosis. The most common culprit is atherosclerosis, which typically affects the artery at its origin, resulting in an osteal lesion. Another important cause is thoracic outlet syndrome, where external compression, often by a cervical rib or fibrous band, leads to damage and subsequent thrombosis, sometimes referred to as effort thrombosis or Paget. Schroeder syndrome when the subclavian vein is involved. Trauma, whether from medical procedures such as central line placement or from blunt or penetrating injuries, can also precipitate thrombosis. Although less frequent, hypercoagulable states and vasculitis must be considered as well. The core objectives in managing subclavian artery thrombosis are clear: prevent embolism from traveling downstream, restore blood flow to the affected limb, address the underlying pathology, and prevent recurrence of the event. Acute presentation and initial stabilization. Patients typically present with sudden onset pain in the upper limb, pallor, loss of pulse, abnormal sensations, and sometimes paralysis. The classic 5 Ps of acute limb ischemia. Occasionally, neurological symptoms such as dizziness or visual disturbances may arise due to retrograde blood flow in the vertebral artery, a phenomenon known as subclavian steal syndrome, or from distal embolization. Immediate management focuses on stabilizing the patient, beginning with airway, breathing, and circulation. Intravenous unfractionated heparin is administered without delay to halt the progression of the thrombus and reduce the risk of embolism while further diagnostic steps are undertaken. Analgesia is provided to ensure patient comfort, and a thorough assessment of the limb's neurological function is completed. If there are signs of a threatened limb, such as sensory loss or motor weakness, surgical intervention becomes an emergency too. Diagnostic workup. Imaging is essential for confirming the diagnosis, locating the thrombus, and guiding treatment decisions. Duplex ultrasound serves as a first-line, non-invasive test that can reveal the presence of a thrombus, evaluate blood flow, and sometimes identify compressive causes such as thoracic outlet syndrome. For acute cases, computed tomography angiography is the gold standard, offering detailed visualization of the thrombus, collateral circulation, and underlying anatomical abnormalities like a cervical rib or extensive atherosclerosis. Magnetic resonance angiography is an alternative for those who cannot receive iodinated contrast, and is especially useful in chronic cases. Catheter-based angiography, once considered the definitive diagnostic tool, is now reserved for instances where an interventional procedure is planned at the same time. 3. Definitive treatment strategies. Treatment is tailored to the acuity of the situation, the underlying cause, and the specific anatomy involved. Endovascular therapy is typically the initial approach for most acute thrombotic blockages, as it is less invasive than open surgery. The procedure involves percutaneous access, usually through the femoral or brachial artery. Catheter-directed thrombolysis is used for acute thrombosis less than 2 weeks old, delivering a clot-dissolving medication directly into the thrombus over a period of 12 to 48 hours, and requires intensive monitoring. Pharmacomechanical thrombectomy devices can aspirate or fragment the clot, often in conjunction with low-dose thrombolytics. Following clearance of the thrombus, it is crucial to address the underlying lesion. Balloon angioplasty and stenting are standard treatments for atherosclerotic osteal lesions, usually involving primary stenting. However, stenting is contraindicated in thoracic outlet syndrome due to the risk of stent fracture or compression. In cases where endovascular therapy fails, where there are chronic total occlusions, thoracic outlet syndrome-related thrombosis, large aneurysms, or trauma, open surgical reconstruction is indicated. Options include thromboembolectomy via either a brachial or transaxillary approach for acute embolic occlusion, and bypass grafting for a durable solution. The most common bypass procedure is carotid subclavian bypass, which uses either a synthetic or venous graft to connect the common carotid and distal subclavian arteries. Subclavian carotid transposition is another method, creating a direct anastomosis with the carotid artery, and is more physiologic though technically challenging. Axilloaxillary bypass is reserved for patients at high surgical risk. For thoracic outlet syndrome, surgical decompression is mandatory. After acute thrombosis is managed, definitive treatment involves either transaxillary or supraclavicular decompression with removal of the first rib and sometimes the scalene muscles. If residual stenosis or aneurysm remains post-decompression, vascular reconstruction may be performed, but stenting should be avoided before decompression. Medical management serves as an adjunct or, in select cases, the mainstay of therapy. Long-term anticoagulation, using agents such as warfarin or direct oral anticoagulants, is prescribed for at least 3 to 6 months, and sometimes indefinitely, especially in the presence of embolism or an underlying hypercoagulable state. Dual antiplatelet therapy, commonly aspirin and clopidogrel, is given for 1 to 3 months following stenting, with lifelong single antiplatelet therapy thereafter. Rigorous control of risk factors like hypertension, high cholesterol, diabetes, and smoking is imperative. IV. Special considerations and complications. Distal embolization is a major concern during intervention, and may be managed with suction thrombectomy or thrombolysis of the vessels in the arm and forearm. Subclavian steal syndrome is corrected through revascularization, either by bypass or stenting, which alleviates symptoms. Special caution is needed to protect the vertebral artery during procedures involving the proximal subclavian artery to avoid inadvertent occlusion or embolization. Lymphatic injury, such as chyle leak or thoracic duct injury, is a risk, particularly during left-sided supraclavicular approaches. In summary, with timely revascularization, the prognosis for acute subclavian artery thrombosis is generally favorable. Surgical bypass offers excellent long-term patency, exceeding 90% at 5 years, while endovascular stenting achieves good outcomes for osteal lesions if the underlying cause is properly addressed. Outcomes for thoracic outlet syndrome are also excellent when decompression is performed. Thank you for joining us today. If you found this discussion informative, please remember to like, share, and subscribe to stay updated with the latest in surgical excellence here on the Everything Surgery podcast. Together, we continue to explore and illuminate the world of vascular care.